severe and critical disease. No, you may get the infection, right? If you have mild symptoms, you can stay home and you're okay. You're not going to require hospitalization. But really, the issue in the first part of this pandemic last year was that the healthcare personnel, the hospitals, were overwhelmed. And we're seeing this right now, for example, in India, right? And so looking at vaccine effectiveness, it's very important to see how it would impact or how it would protect against hospitalization or critical or severe critical disease, because that's what we want. We don't want to overburden, because overburdening the healthcare system will not just affect people who have COVID-19, but also other people who have other diseases, right? Because you have an overwhelmed hospital, all the other diseases, even if they're not COVID-19, will be affected. And so I think that is one thing to remember with this. And in the Siren study here, also from the UK, looking at healthcare workers, where they enrolled over 23,000 participants. Also, they looked at the effectiveness, and a single dose was 70% effective against all PCR infections. So this is not just hospitalization. This is whether you're symptomatic or not, PCR positive cases, it was 70% effective and 85% after the second dose. So this is all infections. Okay, next slide. Now let's go to the viral vector base, and we have two. Well, there's one that's approved here in the US, which is the J&J vaccine. And then the other one is the AstraZeneca, which has been approved in Europe. And I think in the Philippines, people have gotten the AstraZeneca vaccine. So this is data that was just recently published in the New England Journal. These are results from the phase 3 clinical trial, where they did a 1-to-1 randomization of people receiving the vaccine versus those who received placebo. So as you see here, really nearly 40,000 participants were enrolled in this study. The primary endpoint was efficacy against moderate to severe critical disease. And as you can see there, so this is at 14 days after, you probably couldn't even really see there's a difference there between the placebo and the vaccine, but it showed 66% efficacy in preventing moderate to severe critical COVID-19 14 days after vaccination. It was different depending on the country. Like in the United States, the efficacy was 74%. 66% was overall. In the US, it's 74%. But for severe and critical efficacy at 14 and 80, efficacy was 76.7%, and after 14 days, and at greater than 28 days from vaccination, it went up to 85.4%. So the longer it is from days of administration, you could really see the difference between those who received the vaccine and the ones who received placebo. So this is some of the data that was considered when this vaccine was getting evaluated, and it received emergency use acceptance or approval. And that's why some individuals are not able to receive this vaccine. The next slide is the AstraZeneca. So this was, I got this slide from the ACIP, or the Advisory Committee on Immunization Practices. They presented these results to that group, hoping for the vaccine to be approved here. And so this are interim data results from the phase 3 study. Our site participated in both the Moderna, the Janssen, or the J&J, and the AstraZeneca. So we enrolled several participants in this study. The AstraZeneca study, there were more than 30,000 participants who enrolled in the study. There was a 2-to-1 randomization, so two participants per one placebo. 2 participants receiving the vaccine and 1 placebo. The adverse events were very mild to moderate, and they resolved within 1 to 7 days. The data showed that it was 70.4% effective at preventing symptomatic COVID-19. But the interesting thing, again, as I mentioned, look at hospitalization and severe disease. And actually, 21 days after the first vaccine dose, there were no hospitalizations or severe COVID-19 among the vaccinated participants. This is even after the first dose. The other important thing, and I think this is something that some people in the Philippines are thinking, the duration or the dose interval. The study was like 28 days to receive the second dose. But as you can see here, they have data to show that the longer the interval between the doses also showed some higher vaccine efficacy, greater than 11 weeks you could see the efficacy increasing to 81.9%, 8 to 11 weeks, 72.85%. So there is some data there that's showing that increasing the dose interval also increases vaccine efficacy. Now, the thing is, the AstraZeneca has been approved, right, in Europe. And so we have real world data. And this is from the Scotland study that I mentioned earlier. That study did not only look at mRNA vaccine, but also looked at the AstraZeneca vaccine. And so in the last two bullet points, you could see that the vaccine effect was 88% in preventing hospital admission. And this is not a phase 3 data, but this is the real world condition data from Scotland. Next slide, please. Now let's talk about Sinovac. So Sinovac is an inactivated virus. It's not available here in the United States, but it has been used in different countries. We do not have yet phase 3 results published in peer-reviewed journals, right? So it's hard for us to really look and appraise, those journals and really look at the methodology and do analyze and find out whether, how stringent the analysis was in determining the efficacy of this vaccine. So the data that we have right now are based on some interim phase 3 results, but also from data or real world conditions from different countries. And as you can see here, it varies, right? So Turkey, the protection against symptomatic is 84%. Brazil, it's like 51%. So it goes from like 50 to 80 to 84%. Protection against hospitalization there is pretty high there in Turkey, 85% in Chile. Now, one person mentioned what's happening with Chile, right? They were very good in vaccinating individuals with the Sinovac, but right now, a lot of people are getting, are infected and are being hospitalized in Chile, despite the fact that they have a very effective, or they did a really good job at vaccine rollout. Now, in the next slide, this is the data that was presented by Chile itself in the WHO. So first look at the right. These are the early estimates of vaccine effectiveness in Chile, right? This is from the fully vaccinated individuals. So it's 67% in symptomatic COVID-19, 85% for hospital admission, 89% ICU, and 80% death. So very, very good, effective, really promising data there, or good vaccine effectiveness. Now, if you look at the table, and so two things here. There were a lot of individuals or people in Chile that received the first dose but did not receive the second dose. Look at the effectiveness, adjusted effectiveness of the vaccine with just one dose. So partially immunized, hospitalization, 35.65%, not that high. ICU admission, 42.7%. Death, confirmed death, 40.22%. So really not good. And if you look at the number of individuals who were evaluated, so there were a lot of individuals who received the first dose, right? For hospitalization, 2,156. How many were fully vaccinated? 222. So a lot of people were getting the vaccine, but not yet the second dose of the vaccine. And it's probably the reason why. When you just get the first dose, yes, there's an effect, but the efficacy or the vaccine effectiveness is not close to what people would see in someone who's fully vaccinated. So just one dose of the vaccine may not be as effective. This is based on the data, the results that the Chile presented. So fully vaccination would be important. Okay, the next part would be clots. There's a lot of media regarding clots, especially with the Janssen, the J&J vaccine. And so let's go talk about these clots. So what has been shown, right? So first, thrombosis is when blood clots block vessels, either veins or arteries, and it could lead to stroke, it can lead to heart attack, it can lead to different symptoms such as swelling and pain in an extremity, chest pain, some neurologic symptoms. And also what they've noticed is not just thrombosis, but thrombocytopenia, which is a decrease in the platelets. Of course, platelets are important in our body, so that if there is a significant decrease in our platelets, that could lead to bleeding as well. So what did they show? So here you could see the timeline, and this was presented in the ACIP meeting in April 14 and April 23. So very recent slides that's available for public. You can actually go and review all these slides if you want. And so they look at cerebral venous sinus thrombosis. First, so it was approved. Vaccination started in March 2, And then from March 19 to April 12, there were 6 cases of this thrombosis with thrombocytopenia. So the clotting with decreased platelets that was reported to the adverse events reporting system, right? So people who got vaccinated, everyone who got vaccinated, you know that you have to report any adverse events that you experience. And so they had to pause this. And this, of course, there was a lot of news about this. They paused giving the vaccine until they were able to review the data. So what was shown here, so the Janssen vaccine had 6 reports of this thrombosis with thrombocytopenia with platelet counts less than 150,000. I think there was one that was 10,000. Normal is around 150 to 350,000. But there were 6 reports after 6.86 million doses administered. So there was a 0.87 case per million dose administered. They did not report anything in the Pfizer vaccine. And in the Moderna, there were 3 reports per 84.7 million administered, but all 3 only had that thrombosis. They had normal platelet counts, whereas in the Janssen, they had thrombosis plus decreased platelet counts. And so what the patient characteristics is important. These all occurred in women, white females. And the median age was 33. The onset was a median of 8 days from receiving of the vaccine till the symptom onset, and usually starts with some headaches and but none of these patients had any coagulation disorder that would account for those thromboses, and there was only one of them that was using estrogen and progesterone use, had estrogen and progesterone use. None of them were pregnant also. What were the outcomes? One patient died, 3 remain hospitalized. I think 2 of them are in the ICU, and 2 were discharged home. Now, in the next slide, so this is a further reporting. As of April 21, there were 15 cases. As you see there, the cases were all in females, 13 between 18 and 49 years old, and 2 in greater than 50, none were reported in males. So the reporting rate was 7 cases per million in females aged 18 to 49, and 0.9 per million in females aged 50 and above. So there was an association, right? But there is still no clear causal relation. Now, there are some lab tests that they showed that, you know, there was a presence of some of these antibodies against certain platelet factors, right? But there's still no clear causal relation, but there is an association, all right? There is an association. However, the risk, according to the ACP, the benefits of the vaccine, because, you know, getting COVID-19, you also get rates of thromboembolic events, which is much, much higher than what you can get from these vaccine. And based on weighing the risk and the benefit of the vaccine, the ACP believes that the benefits outweigh the risk of these rare events. And so it allowed the continuation of the vaccine to be given to individuals. Of course, with special consideration that, you know, for this particular age group, females 18 to 49, you know, be very wary that you could have there is a rare chance that you can get this. And so be aware of the symptoms. And also there are other options, right? You have the mRNA vaccines that are available. So if you can get those as well. This is actually the similar recommendation by the European Medicines Agency, because some of these thrombosis was also reported in the AstraZeneca vaccine. Okay, next slide. So now let's talk about variants. What are these variants? People have been talking about variants. It's all over the news. What's going on with the variants in the vaccine? So let's just spend a few slides talking about these variants. Okay, so what are variants? Coronaviruses or RNA viruses, usually when they replicate, it's error prone. Their ability to when there's viral replication, the process is error prone. So every time they replicate, there are mutations that occur. And these mutations allow these viruses to constantly evolve. The emergence of variants comes from this particular aspect, right? As they replicate, there are a lot of errors formed, mutations are formed, and so variants emerge. And these variants can emerge and can also disappear as after emerging. However, there are some variants that have a viral fitness or an advantage against other strains of the virus or other variants. And so some of these variants persist. For example, they're more transmissible, or they're able to escape neutralization by vaccine or treatment. And so because of that, they have an advantage over the other variants, and that's the reason why they persist. While others probably will disappear after some time, the ones that have a selective advantage over the others will therefore persist and can stay in the population for some time, as you can see in the next few slides. Okay. And so in the next slide, there are two things I want to remember: variant of interest and variant of concern. Okay, variant of interest, what does that mean? So again, there are a lot of mutations happening, and then there's an emergence of a variant. Now, if the mutations or the genetic markers of that variant is associated with, changes in receptor binding, increased transmissibility. So it's like, oh, because it has this mutation, this virus theoretically will therefore be more transmissible. Then it becomes a variant of interest, right? Because there is a potential for this variant to actually persist and cause a lot of disease or more severe disease or more transmissible based on the changes that happen in the genetic markers. What is it? How is it different from variant of concern? Variant of concern, yes, you have those changes, but now there is evidence. There is real life evidence that it has increased transmissibility, more severe disease, or it significantly reduces neutralization of antibodies from people who got the infection before, or people who are vaccinated, or certain treatments or vaccines given against it. There's already significant evidence that it is able to be less susceptible to these things. So evidence on impact in diagnostics, treatments for vaccines, there's evidence there, evidence of increased transmissibility, evidence of increased disease severity. So although there may be a lot of different variants, and there are a lot more variants of interest, people are, the scientists and the public health people are looking at these variants, but once there's already evidence that it is doing something with transmissibility, severity, and ability to evade, neutralization of the antibodies, then it becomes a variant of concern. And there are 5 that are present in the United States right now that are variant of concern. So the next slide is the first one, which is the B117, the UK strain. So this has been circulating in the UK since September. And when it started circulating, it was temporally associated with a rapid increase in cases. It was first identified in the US in December. And if you can look at that figure on the right, look at B117 early on, just a little there, but as of the early April, you could see that it's already majority of the variant that you see here in the United States is, I think it's 56 or 57% is already the B117 variant. Why is that? Well, first look at what happened. There's evidence now that it has 50% increased transmissibility, right? So it's easily transmissible, and that's probably the reason why you could really see a lot of cases. And indeed, when it was first noticed in UK, there was a temporal association with a rapid increase in cases. Now, there is also a potential for increased severity. When they look at hospitalization and case fatality, they said, oh, this could be more severe. There was a recent paper, though, that was published in Lancet Infectious Diseases, where it showed no association with increased severity. So I think, there is still some data to show otherwise, but there is also data to show that there are higher hospitalization and case fatality if someone is infected with a particular variant. The good thing is there's no impact on monoclonal antibody treatments. Now, there is a B117 that has another associated with a different mutation that could affect this. And also here, it has minimal impact on neutralization by convalescent and post-vaccination sera. So someone who became infected or who was vaccinated, the serum would have antibodies, right? So they test whether those antibodies can neutralize this variant. And for 117, there's minimal impact on neutralization. So it's okay. In the next slide, you see the other 4. The first one is the 1351, which is the South African variant. It was initially detected in South Africa in December last year and went in the US in January of this year. It also has 50% increased transmissibility. But we don't see, if you look at the figure, it's not yet there, right? You don't see that as a significant variant circulating in the United States. But the important thing to remember is that it has significant decreased susceptibility to certain monoclonal antibodies. And its ability to be neutralized by neutralizing antibodies in convalescent or post-vaccine sera is also reduced. So this is important to consider. The Brazil one, or the P1, was identified in travelers from Brazil that were tested in a routine screening in an airport in Japan in January, was also detected in the United States in January. here it has significant decreased susceptibility to certain monoclonal antibodies. And there are treatment studies going on using these monoclonal antibodies. And so since there's evidence that it has decreased susceptibility to that, it became a variant of concern. There's also reduced neutralization to convalescent and post-vaccine sera. And then the last two were the California, this is the United States California variants, 1427 and 1429, identified in California in 2021 and was classified as concern in March. So there's 20% increased transmissibility. So because there's evidence that has increased transmissibility, therefore it became a variant of concern. There is modest decrease in susceptibility to antibodies, but we don't know what the clinical implications of these are compared to 1351 and P1, where there's really significant decrease in susceptibility. And there could also be reduced neutralization by convalescent and post-vaccine sera. So you could see that it is there circulating. If you also look at the figure, there's a 526 that's there, which is in, what color is that? Violet? I don't know, that pink? That is actually, I'm sorry, I don't know my colors. But that is the New York one. And it's not a variant of concern yet, it's a variant of interest. If you want to look at, there's a tracker for this in the CDC, but also look at the European tracker of variants. In the European, actually, one variant of interest is P3, which is in the Philippines. And it's a variant of interest because based on the genetic markers, it could be more transmissible. But it's not a variant of concern. Okay, next slide. So why is this important, right? And this is a recent paper that was published in the Lancet Infectious Diseases, where it shows the risk that one vaccine escape variant can occur, or the probability of that. And I think the important point to remember here is that if there are a lot of cases, if the viral replication continues to happen, you could see that the risk of developing a variant that will escape the vaccine is significantly high. I mean, well, it's very high. You can look at the probability of that red one, which is 50,000 daily cases. If you have 50,000 daily cases for 5 or 6 months, the vaccine escape probability very high. Whereas if you have that blue one, which is 1,000 cases daily, the risk of probability is high. Because again, let's go back to the science that we talked about. These mutations occur when there is viral replication. So if you decrease viral replication, if there are very few cases that are happening, then the chances of these mutations happening and variants emerging would be decreased. Now, is there data to show this? Well, there's one that was recently published, is a correspondence to the editor in the New England Journal, which is published which is in the next slide. This is seen in Qatar. Where they looked at vaccine effectiveness against infection. So these are individuals who receive the Pfizer vaccine. So look at the first part, infection. It says that the effectiveness after 14 days after the second dose is 89.5% of protection from getting infection with the 117 or the UK strain, although the effectiveness is decreased in those who had the South African strain, 1351, it went down to 75%. But if you click again, so yeah, you see that. And then next, when you look at disease, I think the boxes are a little off, but what I wanted to show here is that when you look at the disease, severe, critical, or fatal caused by the 117 variant, what they showed is that it's still 100% effective 14 days after the second dose. 1351 variant, the same. Any SARS-CoV-2, 97.4%. So still effective. And this is data just from one country, from Qatar. And I think as more and more people get vaccinated and that we see these different variants that are circulating in the community, there will be additional studies from different countries showing how effective these vaccines are. But the important point to remember is as long as there is, a lot of people aren't getting vaccines and as long as there's a lot of cases happening in different countries, then the risk that there will be a variant that will escape the vaccines that we have available for will be higher. Okay, next slide. So what are the take-home points? First, real-world data show that the mRNA vaccines are effective. So it sort of like confirms some of the findings that we found that were in the phase 3 studies. Phase 3 data from the viral vector, the Janssen AstraZeneca, also showed some effectiveness in preventing symptomatic, severe, or critical COVID-19 disease. Sinovac, still varying cases, right? A varying efficacy from 50 to 91%. But the important thing to remember with the Sinovac is that partial immunization, the efficacy is lower than that of those who are fully vaccinated. Another take-home point that there is an association observed between the Janssen vaccine and the thrombocytopenia syndrome, but these events are rare, and according to the ACIP and also the European Medicines Agency, that the benefits of receiving the vaccine outweigh the risk for these rare events. And then the final take-home point that currently there are 5 variants in the United States that are variants of concern, which means they have evidence that they impact transmissibility and susceptibility to certain treatments. And with that, I'd like to thank everyone for listening. These people who are thanking members of my lab. I think Candy.
Yes, thank you so much, Dr. Makatangay. Next slide, please. So before we go to the Q&A portion, I just want to give you some information on what happens when you get fully vaccinated. So I think this is very important. But first, let's define what fully vaccinated means. So you're considered as fully vaccinated 2 weeks after your second dose of the 2-dose series. For example, you get the Pfizer vaccine or Moderna vaccine, or 2 weeks after a single dose vaccine like the J&J Janssen vaccine. Next slide. So if you've been fully vaccinated, what can you start doing, right? So you can start gathering indoors with other fully vaccinated individuals without wearing your mask or without social distancing. You can also gather indoors with other unvaccinated people of the same house, of one other household, without masks or socially distancing, unless one of those people or anyone they live with has a high risk for acquiring severe illness from COVID-19. You can also gather or conduct activities outdoors without wearing a mask, except if you're going to be in a crowded setting or venue. Next slide. So what about travel? So if you travel within the United States, you don't need to get tested before or after traveling or self-quarantine after travel. However, if you're going to be traveling outside of the United States, you need to check the your destination's protocol for quarantining. So these are the guidelines from the CDC. So you do not need to get tested before leaving the United States unless your destination requires it. You still need to show a negative test result or documentation of recovery from COVID-19 before boarding any international flight to the United States. And you still need to get tested 3 to 5 days after international travel. You do not need to self-quarantine after arriving in the United States. Next slide. So what if you get exposed to somebody with COVID-19 and you're fully vaccinated? So if that happens, if you've been around somebody who has COVID-19, you don't need to stay away from others or get tested unless you have symptoms. However, if you live in a group setting, like a group home or detention facility, I don't think anybody here is in that location. But if you know somebody who is in a group setting and are around people who have COVID-19, you still need to get tested even if you do not have symptoms. Next slide. So we will now open we are now open for questions. So we are going to go through some questions that have been emailed to us before the webinar. So for our first question, somebody sent a message. What is the difference between quarantine and self-isolation? So I just want to define the difference between these two words because there's a lot of confusion about this. So when you quarantine, so the term quarantine is used to keep someone who might have been exposed to COVID-19 away from others. So if you've been exposed to somebody who is sick with COVID-19, then you quarantine, right? And the quarantine guidelines may differ in different countries. What about self-isolation? So the term self-isolation is used to separate sick people from healthy people. So if you have been infected with COVID-19, then you self-isolate, whether in the home or in the hospital. And I know that in some countries or some locations, these terms are used in different contexts. So, but these are the definitions from the CDC. Next slide. So we got a question from Dr. Jay Valencia, and I'll address this question to Dr. Makatangay. So for Moderna and Pfizer vaccines, can these vaccines affect the DNA? You're on mute, Dr. Makatangay.
No, so the mRNA vaccines actually don't even go into the nucleus. So it will not affect the DNA.
Next slide. Next slide. So, so we have one more. These are the questions again that we have received before this webinar. So, if I had one brand of COVID vaccine, can I get a different brand for the second dose?
I think there's no data yet to support that, and I think people are looking into this, whether this is available. But right now, it's not yet recommended by the CDC because there's insufficient data to show whether if it's safe or if it's as effective. I personally, I don't think it's going to be an issue, but we have to look at the real world data or this data in different studies. And this is actually for the second one as well, that with the vaccine overdose or vaccine clash, this would be two different types of vaccine that's being administered. There's no data with that yet. There is, and I think people have been seeing news about the possibility of a booster shot. And I think like Moderna is planning on and is looking into this. And I think part of this is to be able to address some of those variants that may have reduced susceptibility to that, but we don't have the data yet and it's not yet approved.
Okay, thank you. And is there a need to check COVID-19 PCR prior to getting the COVID vaccine?
No.
When are you considered immune after getting the COVID vaccine? So I think I've answered that question earlier.
And I think there was someone in the chat talking about whether it's safe to get the vaccine if you've had COVID-19. Yes. Initially, when vaccines were being rolled out, the recommendation is, maybe you can get it 90 days after, you get the vaccine, you wait 90 days. And one of the reasons for that is, so that other people who haven't gotten any immunity whatsoever could get access to the vaccines first. That said, I think now the idea is as long as you're no longer in acute infection and you're no longer isolating after getting infected, you can get the vaccine. There is data that was shown in March at the Conference on Retroviruses and Opportunistic Infections that someone who got COVID-19, they received the first dose of the vaccine and they showed the neutralizing antibodies and they were really high. So someone who got COVID-19 and got the vaccine, even just one dose of the vaccine, and they were comparing it to someone who was not infected and got 2 doses of the vaccine, the levels of these neutralizing antibodies and the T cell responses were much higher after 1 vaccine dose in someone who got infected compared to those who got 2 doses. And so what this means clinically, right? So this is just basically in the lab test. We don't know, but that really showed that you can get it. And what basically happens is if you've got the COVID-19 and you recovered, that vaccine sort of like becomes a booster for you. You get suddenly higher neutralizing antibodies.
Thank you. We have a question from Dr. Kathy Prado-Ona. So what do you have, what data do you have about variants in India?
I think the one in India is a variant of interest in the European. It's what 1617, I think 1617 1617.3. And it could have an effect on its ability to reduce susceptibility with neutralizing antibodies. But so this is since it's a variant of interest, it means that there are genetic markers that could show that there may be an association that it could have reduced ability to be neutralized by the antibodies, but it's not yet a variant of concern. So there's not significant evidence, and I think they're gathering data on that right now. It's not yet a variant of interest. I don't believe it's a variant of interest in the US, but in the European, in the EU, it is already a variant of interest.
Thank you. So we have another question from Dr. Lorenzo Bernardino. Do we need to check our titers post-vaccination? There had been instances that the titer is done in Manila for Sinovac and AstraZeneca vaccines.
No, we don't regularly do that. You typically there are certain studies that we're doing right now, like for example, people who were vaccinated and then got breakthrough infection. There are studies that are looking at those titers and are also sequencing the virus to see why they had this breakthrough infection. But regularly, or typically, if you got the vaccine, we don't typically check the titers.
Candy, I think the answer to that would be in a clinical study, yes, but
Yes,
for
in a clinical study, yep.
like a community monitoring, it's not indicated.
Thank you, Dr. Lirio. So we have another question from Dr. Jay Valencia. Can we give the COVID vaccine to pregnant women?
Yes. So the initial studies, the phase 3 studies excluded pregnant women. Although I remember in the Janssen, I think one of my friends, she was breastfeeding and she was enrolled in the Janssen study. So they don't have data on that yet. But in the AstraZeneca and then the other studies, pregnant and breastfeeding women were excluded. However, based on the effectiveness of the vaccine, the American College of Obstetrics and Gynecologists actually recommends receiving the vaccine from pregnant women.
Thank you. Can you comment on ACE inhibitors and ARBs in the setting of COVID infection? And should people stop taking their ACE or ARBs? And in what mechanism is COVID associated with ACE inhibitors?
Grace, are you?
Yes, so I think that this is a good question because this was asked very earlier on during the pandemic. Basically, the message is to just continue taking your blood pressure medications. There's really no reason why you should stop taking it. Might be even dangerous. But the theory behind that is that there's some upregulation of the receptors in the lungs, and that serves as a binding site for the virus to gain entry into the cells. And so when that happens, they feel that it becomes more efficient and you can get sicker, but there's really no evidence that these drug classes pose harm to patients with COVID-19 or whether you should stop or not. I would recommend basically just continuing those medications, and that includes NSAIDs like Motrin, Advil, Aleve, and those are the brand names.
There was a joint statement by the American Heart Association and the ACC to that effect, to not discontinue.
Thank you. Is it safe to take NSAIDs after getting the COVID vaccine? I heard that this can lower my immune response to the vaccine.
Yes, you can. So the recommendation was to not take NSAIDs before getting the vaccine because there's a theoretical risk of decreasing the immune response. But after, if you're having pain, headache, or whatever, you can take it.
Okay. And will a short course of prednisone between doses of the COVID vaccine lower my immune response?
I think we're looking at data. Theoretically, yes, because it decreases immune responses.
Thank you. And another question from Dr. Lorenzo Bernardino. Has there been any recommendations to give the COVID vaccine to children younger than 12 years old?
So there are studies going on right now for children 6 months to 12 years, I think. There is already data on those 12 to 15, or 12 to 16. And so I think that's going to be the next thing, giving the vaccine to teens. But there are ongoing studies for those 6 months to 12 years. And so we're waiting for those results and to determine whether they can be given the vaccine.
All right. Next slide, please. So we'll talk about some information about supplements. Are there vitamin D, vitamin C, and zinc effective in treating COVID-19?
Yeah, so I think there were initial results or data, I think with vitamin D, that some people who are vitamin deficient had increased risk for COVID-19 illness. But there have been studies to actually look at vitamin D, C, and supplements in people who have COVID-19. And so there was a paper that was published in JAMA Network Open where they looked at high dose zinc, vitamin C or ascorbic acid, or both versus standard of care in outpatients who got SARS-CoV-2 infection. They were randomized 1:1 to 1:1. They enrolled 214 patients, and the results showed that there was no difference between the arms. So compared to standard of care, high dose zinc, ascorbic acid, or both, they did not significantly alter or decrease duration of symptoms compared to standard of care. And I think there are other studies that are ongoing right now looking at this, but this is the one that was published in JAMA Network. And based on that data, the CDC says there's insufficient evidence. They're not saying, no, don't do that, but there's insufficient evidence. What they're recommending against is taking zinc supplements at doses higher than those recommended for daily intake, daily supplementation. They recommend against that. Now, for vitamin D, as I mentioned, there was a retrospective cohort study showing that likely deficient vitamin D was associated with an increased COVID-19 risk. But then there was a randomized controlled trial that was published in JAMA where patients who got COVID or moderate to severe COVID was given a high dose of vitamin D, but it did not show significant difference in the length of stay. And so based on these results, the CDC says there's insufficient data against the use for or against the use of this supplement. And what they want and what they're waiting for are additional studies to actually guide them to see whether there may be a potential benefit for these supplements.
Andy, can I add to that?
Yes.
So basically, when I get asked by my patients, should I be taking vitamin D? See, what should I be taking so that I could treat my COVID if I'm positive for COVID, or even to prevent it? There's just, it's really, there's no evidence, like Dr. Makatangay said, but, if you decide to take it in the proper dose. It's not harmful. Whether it's going to work or not, it's up to you, but we won't recommend it, but we won't, if you want to just take it, it's okay too. It's not going to cause any harm.
Now, can you comment on ivermectin for treatment of COVID infection?
Yeah, so there's a lot of discussion. I think everyone's been talking about this here. So first, there are some data, there are some cell culture data showing that ivermectin is able to inhibit replication of SARS coronavirus 2, right? And this has been seen in cell cultures, and this is sort of like the rationale of whether we should give ivermectin. Now, pharmacokinetic and pharmacodynamic studies suggest that achieving the plasma concentrations necessary for antiviral efficacy would require doses of 100-fold than those that have been approved for humans. So when they looked at those doses in the cell cultures, and then they tried to look at it whether they can recreate that in humans, it would require 100-fold data. Now, that said, there are a number of studies, right? So there are a number of studies. There were some retrospective cohort studies. There are some randomized trials. As of now, the recommendation is that there's insufficient data to recommend the use of ivermectin. Why is this? Some of the clinical trial data that has been shown showed benefits. Others had either no benefits or some with worsening. All right, so there's varying information. And then if you actually look at some of those clinical trial data, although there are some results that say, oh, there's reduction in inflammatory markers, shorter time to clearance, or lower mortality rates. But some of these studies first have very small sample sizes. Number two, there were various doses of ivermectin or schedule of ivermectin used. So there's not like one specified dose or schedule that have shown, consistently to provide benefit. The other is that there were some of these studies were open label, or there are some of these studies, the patients actually receive concomitant medications in addition to ivermectin. So you don't know whether it could be attributed to ivermectin or to this other concomitant medication. The severity of COVID-19 is also not always described. The outcome measures are also not clearly described. Now, does this mean that there's like zero chance? I think there are additional studies that can be done for ivermectin, but as of now, the available data and the robust methodology that has been shown in these previous studies, or the methodology has been shown, or the analysis that has been shown, the CDC said that there is insufficient data to actually recommend the ivermectin. Could this be changed in the future? We don't know. it's possible, right? If there's additional evidence to provide benefit, but as of now, it's not. And so the recommendation, the summary statement is there's insufficient data, and I think there are also statements that were provided by the specialty groups in the Philippines saying the same thing.
Thank you. So we have two questions actually from Jeffrey Pagulong. The first question is, so I guess he's asking, what is more suitable for younger or older folks? Is it the mRNA vaccine or the inactivated vaccine?
So the data is different. So the mRNA, there was some real world data that I showed earlier in the first slide where there was 94% effectiveness in people 65 and older. The median age there was 73. So each of these vaccine studies actually looked at, so they apart from, the overall effectiveness, they also had subgroup analysis where they looked at, elderly individuals, and similar to the varying rates of effectiveness overall, there are also varying rates of effectiveness based on the study population. So what I would recommend is to look. So for the mRNA vaccine, they showed 94% effectiveness. And then there's also pretty high effectiveness in some of the viral vectors based on their particular studies. And in those published studies, they really divided. They made sure to put in the analysis in those individuals that are older than 65 to show whether they're more effective or not.
Thank you. And the second question from him, from Jeffrey, is it safe to get the vaccine if you've had COVID-19 and your body's immune system took care of it already?
Yeah, so as I mentioned earlier, yes. So you can get the COVID-19 vaccine. Typically, we recommend it after the person has gone through the acute infection and is no longer isolating. You can get it. It actually somehow serves like the first dose serves like a booster to increase your neutralizing antibodies. But yes.
Thank you. And can you comment on the vaccines and its effect on the viral transmissibility?
So there are studies. So the issue is that the primary endpoint of the vaccines are usually symptomatic disease rather than transmissibility. Although there are certain studies, like I mentioned earlier, was that one of the real world studies. The one in Scotland, I think, the Pfizer study where the one in UK where they actually looked at PCR positivity, and there was some effectiveness of the mRNA vaccine in that. But again, the previous studies, phase 3 studies, and all of those usually look at symptomatic or moderate to severe or critical infection as the endpoint, and not infection, which means you may get infected, but you're protected from getting severe or critical disease.
Thank you. So this question is for Dr. Grace Lirio. Can you comment on herd immunity?
Yes, herd immunity. I think we discussed this at one of our meetings. So really several things that we need to consider. But the bottom line is that it might not be possible for us to get herd immunity, at least here in the United States, only because that's disappointing. According to a recently published paper, they say that herd immunity, you have to have 60 to 70% of the population so that you can gain that. And with vaccine hesitancy, that's a problem. And so, really until we get to that point, we probably will not get to herd immunity. Now, I think I mentioned this at one of our talks, whether we should expect this COVID to go away completely. I think we need to start looking at it from a practical standpoint, where it might continue to be, it might eventually not become a pandemic, instead be an endemic, meaning that it will continue to circulate in certain pockets of the global population for years to come. So like Dr. Buencamino said earlier, we all just need to be practicing those responsible behaviors, hand washing, in using hand sanitizers and those things that will protect us from other infections anyway. And then go get your COVID vaccine is what I would say about that.
Thank you. If I tested positive for COVID but remain asymptomatic, when will it be safe for me to get off quarantine? Dr. Lirio, do you want to answer that question?
All right, so I'm looking at one question here. So I think that, you know, if you're asymptomatic here, it's different in different, the regulations are different in different countries. So at least here, if you are asymptomatic for 3 days, I think that's, you know, you could, you know, I think you should define what quarantine and isolation is in your place of residence. But here in the US, quarantine is just like Dr. Buencamino said, you have to, there's a different, you know, set of standards for the definition of quarantine. And, but here in the US, 3 days, if you're asymptomatic, you can really, you know, just go out already and do normal stuff, but you'll still have to do the hand washing and those public health protocols that have been established.
So the other thing as far as symptoms, right? So you have to be afebrile for over 24 hours and 10 days from the onset of symptoms, provided you continue to be afebrile. Some people are, because there are some symptoms that are more chronic, like, you know, decreased inability to smell and taste. These are not considered as part of those symptoms wherein it's like, as long as you no longer have the symptoms, because some of these actually can persist for a prolonged period of time, and you're not expected to isolate as long as you have some of those chronic symptoms. It's really the fever and those acute symptoms that they're talking about when to finish isolation.
All right. One last question. I received a AstraZeneca vaccine and had severe headache. I don't want to get the second dose. Can you comment on that?
It's not a contraindication. So you can receive the vaccine and then just take an analgesic afterwards. The only contraindication of getting the second vaccine dose is if you have an anaphylactic reaction. Based on certain data, as I presented earlier, the effectiveness is not as strong after the prime. I mean, there is some effectiveness there, but it's not as strong as becoming fully vaccinated with the AstraZeneca vaccine. So.
Thank you so much. So that's our last question. I will transfer the floor to Dr. Grace Lirio for our closing remarks.
Yeah, Candy. There was actually a question on some Chinese herbal medicine from Lorenzo, and we don't know much about it, so I'm sorry. We couldn't.
Well, I think there's no recommendation yet. There are some papers that show potential benefit into it, and so I think we're open-minded and seeing if there are additional studies that the CDC or the regulatory committees may be able to give us further guidance on whether this would be recommended. But as of now, there's insufficient data. That said, there are papers that show some benefit.
Mm-hmm. Thank you. Okay, so really, thank you very much for such a lively discussion. We got so many questions from our audience. So again, my name is Dr. Grace Perez Lirio. I'm the former president and current board chair for the Philippine Medical Association of New England. And on behalf of the Philippine Medical Association of New England and our community, we are very appreciative of Dr. Makatangay's time and expertise and for sharing generously what you know about COVID. And this is really very helpful for our organizers, especially our Vice President and President, Dr. Buencamino and Dr. Ona. They've been working tirelessly to provide this educational activity to everyone. So thank you very much for all your efforts. I learned a lot today, and I hope many of you share the same sentiments. PMA is a nonprofit organization, and one of our missions is to provide information to our community. And we are very thankful for people who have joined us over the past year, learning more about COVID when we deliver information as we know it. We wanted to invite you all to some of our activities. We have a PMA wellness program in Newberry Street. This is on one Saturday a month, where we feed people who have home housing insecurity. And that's a Saturday morning where we volunteer to do some, feed them and do some kind of educational activity as well. We have a general assembly for members only on June 20 in June. And this will be in Hanover, Massachusetts. That's going to time and details about that will be determined and announced later on. We are also going to have our Volunteer Appreciation Day on August 13th in Brewster, Massachusetts. More to come on that in terms of timing and the schedule. We are, sadly, we will have to say goodbye to our president, vice president, and all the other executive committee, and welcome new ones. So I'm looking forward to that. We have election of our officers in September, and nomination will start, I think, during the Volunteer Appreciation Day. So, we are hoping we will have a robust nomination bucket for people who will be our incoming officers. We also are planning our Christmas party where we will have our induction of officers, incoming officers, on December 12th from 1 to 5 p.m. at Marriott in Cambridge. So we will be posting this in our website, and we just do invite everyone to be part of our community. Also, I wanted to say that, on behalf of everyone, to all the frontliners, to all our doctors, nurses, I'm very happy to be alongside with all of you, and for, being very persistent and dedicated to our mission of taking care of our patients. We all have much to be proud of with our Filipino colleagues here in the US and also in the Philippines. We also wanted to say Happy Mother's Day, and hopefully you can celebrate safely. And if you have any questions, you can send us an email. Anything that I missed, let us know. Have a good day, everyone.
Have a good day,
Thank
everybody.
you.
Happy Mother's Day.
Mother's Day. Thank you.